$26 billion in settlements around the world. Florida tapped to receive hundreds of millions of dollars from manufacturers and distributors of pain medication for their role in the opioid crisis. Companies accused of deceptive marketing or downplaying the associated risk of addiction. About $75 million for Palm Beach County, $7.6 million for Martin County, $13 million in St. Lucie County, nearly $7 million in Indian River County, and just over $3 million for Okeechobee County. A problem created decades ago that communities and health experts are still trying to slow down. Florida is slated to get about $860 million in an opioid lawsuit settlement. How, in your opinion, how should that money be distributed? What do you think should be done with that money?
That is such a tough question. It's a lot of money, but a lot of lives have been devastated. A lot of lives have been lost. A lot of lives have been irreversibly changed. So what do you do?
The troubling trend can be seen in this graphic from the CDC. From the late 90s to 2020, a steady climb in overdose deaths in the United States. 75% of the nearly 92,000 drug overdose deaths in 2020 involved an opioid. 99 people die every day from overdoses involving synthetic opioids. Zeroing in on Florida, fentanyl stands out. This is the final 2020 annual drug report from the Florida Department of Law Enforcement. Fentanyl caused nearly 2,400 deaths in 2018. That number jumped to 5,300 in 2020, 10 times more than oxy, 7 times more than heroin, 4 times more than meth. And deaths by county, red means danger, 25 or more deaths per 100,000 people. FDLE data shows Palm Beach County, Martin, and Okeechobee counties are on fire. St. Lucie County is not far behind. The situation's still at a point where alarms continue to go off this summer.
I'm Attorney General Ashley Moody with a warning for parents like me as summer break gets underway for students. Drug dealers are using social media to sell dangerous drugs. We call them digital dealers, and they are using some of the most popular apps to target children. They push prescription opioids, but often deliver counterfeit pills laced with fentanyl instead. Just 2 milligrams of this synthetic opioid is enough to kill a full-grown adult. The scary part is users often have no idea what they are taking, and too many parents have found out too late that just one pill can kill.
Earlier in our series, we heard from State Attorney Dave Ehrenberg, who said Florida has been a hotbed for the opioid crisis.
By the year 2010, we had more pain clinics in Florida than McDonald's in Florida.
Back in the 90s, drug makers, insurance companies, and pain specialists pushed for opioids as a treatment for common ailments. Overdose deaths took off, and many viewed prescription painkillers as a big reason. As communities passed more restrictions, some people turned to heroin and fentanyl. Dr. Tiffany, can you explain how the drug companies drove the opioid crisis in the early 90s?
In the early 90s, I trained in the 90s. I went to medical school, and I recall that we didn't really give a lot of pain medicine for anything, even broken bones. Over time, things like the pain scale became the most important thing and the fifth vital sign. Pain is very subjective, and everyone experiences pain differently. Unfortunately, we still don't have a great handle on exactly how many shots of pain medicine it actually takes to create an addiction. So if you have a room full of 100 people and you give everyone a shot, then maybe 1 or 2 will be an addict. you have a room full of 1,000 or 1,000,000 people and you give everyone a shot, then you see you have a much bigger problem. And so because pain became such a subjective thing that had to be treated by everyone got a lot more pain medicine and access. And unfortunately, there are addicts, and some of that is genetic, some of that is predisposed. And those people, unfortunately, had addiction created for them, whereas they may not have had that without the big push for the pain scales.
In 2016, the CDC came out with new voluntary guidelines. The nation's top public health agency said opioids should not be the first treatment for chronic pain. Doctors should try other medications or non-drug options first. Doctors should limit opioids prescriptions for short-term pain to 3 days and to prescribe the lowest dose possible. In 2022, the CDC is looking to roll back limits on some painkillers, focus on individualized patient care, and explore more options for treating short-term acute pain after surgeries or injuries. I sat down with Dr. Aisha Shakoya, a doctor of pharmacy. Though she's focused on her future as she's about to have her first baby, we talked about the future with opioids and potentially new recommendations from the CDC for pharmacists to help reduce addiction and abuse. One of the proposals is to help patients who are receiving high doses of opioids to wean off the drug gradually.
Yes.
What do you think about that?
Yeah, I think that's important because withdrawal symptoms could actually kill an individual. And so we have to be very careful how we taper a patient off of an opioid that they're addicted to or they're taking high doses of. Because one thing about opioids, how they work is that when you take it for the first time, you have all these receptors in your brain that are responsive to it. But after some time, if those receptors have been exposed to the drug too long, then it doesn't have as much of an impact. So then it starts making more receptors because it feels like it's kind of getting desensitized to it. And so then you need higher doses just to be able to control your pain. Now, if automatically you stop, right, you have all these sensitive receptors waiting for you to take the opioid, and then your body will just start shutting down in different ways because it's like, where's my opioid? You created all these sensitive receptors in my brain now. I want more of the opioid. And then this is how you become tolerant. And so it's important that, patients who are on high doses of those opioids, we slowly taper them off. So you're still giving the body what it wants. But after some time, it's like, I don't need that dose anymore. The dose you were taking before, okay, I can take a little bit of a lower dose. Okay, yeah, we can go lower now. Okay, this is good. And the body is slowly able to not get used to that high dose anymore. And it's crazy because this concept also applies to antidepressants too. So antidepressants, similar like to opioids, you can't just stop them automatically. If you start taking them, you can't just say, hey, I don't want to take this anymore, because then some side effects will occur because your body's been so sensitive to it. And so when you just stop it automatically, your body's like, whoa, what happened? I like that. We must always taper them because of the effect it has on hormones and the effect that it has in our brain.
Recent data shows that after the new opioid guidelines in 2016, clinicians were prescribing non-opioid medications for pain. Do you think that trend will continue if the guidelines are changed? If so, why? Why or why not?
So that's a good question. Right now, currently, with the guidelines, I think the guidelines are fair. We go based off evidence-based medicine, and evidence is showing that chronic use of opioids in the use of chronic pain that's not associated with cancer or palliative care does actually contribute to worse outcomes. It can lead to alcohol abuse. And so it has been shown that using non-opioid means can help combat those worse outcomes for patients.
One of the reasons the CDC is updating the guidelines is because studies show that Providers, including pharmacies and insurance companies, were using this document to reduce the use of opioids, even if patients really needed them. Do you think this is a justifiable reason to change the guidelines?
That's a good question. I definitely feel when it comes to determining whether a patient would benefit from opioids, I feel like that should be in the hands of the provider. I do not feel that insurance companies or pharmacies or PBMs should be responsible for determining whether a patient should get opioids or not. Ultimately, this should be up to the provider's discretion to see if a patient can truly benefit from this after exhausting non-opioid measures, of course. And so I don't know if this will change the guidelines, but if people have been ignoring the fact that patients could potentially benefit from opioids and are completely excluding it for certain patients, perhaps they need to use less strict language in the guidelines. But I feel like the guidelines are pretty clear in that, they're not against opioid use, but to just be very careful and educate patients about the risks associated with them and to use it more as a last line measure after you've exhausted all other options.
Do you think restricting access to opioid medications for patients experiencing pain negatively impacts the patient-clinical relationship?
Definitely.
Why?
Yes. I feel like if a patient is not, one thing about pain, it's very subjective, right? It's not as objective as other disease states. So if a patient is in pain and despite trying all options, it's going to affect their quality of life and hence is going to affect the relationship they have with their provider or doctor. It is important not to restrict too strictly for patients when it comes to opioids, but education I feel is the most important. Letting them know what are the benefits with them, but also what are the risks, and could it be beneficial in their situation? Will it be beneficial in targeting their pain specifically? Because there's some types of pain that opioids are not that beneficial in.
Like what?
For instance, neuropathic pain. Opioids are generally not our go-to for that. Ideally, we want to use drugs like antidepressants or a drug like gabapentin or pregabalin to help target that nerve pain or that neuropathic pain. And that pain is usually described as like a stabbing, stinging type of pain. So opioids are usually not the best go-to for that type of pain.
The pharmacist acts as a sentry to the state's prescription opioid supply. And a key tool is Florida's prescription drug monitoring system called eForce, launched in 2009 by the state legislature. One function is to track MPEs, or multiple provider episodes, also called doctor shopping. It's where a customer shops around to get their hands on more prescriptions. In 2012, the system flagged more than 2,800 people who had one or more controlled substance prescription drugs prescribed to them by more than 5 prescribers and dispensed at more than 5 pharmacies during the first quarter of the year. Fast forward 9 years to the end of the second quarter in June 2021. Those numbers fell to 456 people. That's an 84% drop. More safeguards in the prescription pill pipeline, but still people are dying. The latest numbers available from the Florida Medical Examiner's report to the FDLE show in the first 6 months of 2021, Florida saw a 5% bump in opioid-related deaths compared to the same time in 2020. The drugs causing the most deaths: fentanyl, cocaine, and meth. Deaths by fentanyl increased by 9%, and deaths by fentanyl analogs increased by 40%. The surge led to action at the state level.
Florida is experiencing an influx of new synthetic opioids, more powerful than fentanyl. In fact, some of these substances are so under the radar, they haven't been banned in Florida until now. Today, I'm taking swift action to outlaw 8 synthetic opioids known as nitazines. We do not know exactly how prevalent nitazines have become in the illicit drug market, but we do know that Florida law enforcement has identified more than 260 cases involving these substances since 2020, including more than 80 so far this year. These drugs have also been linked to at least 15 deaths in our state. The scariest thing about these drugs is that users often have no idea they're taking them. Like fentanyl, nitazines are being mixed with other more common drugs and sold to unsuspecting users, often with deadly consequences. We are in the midst of a national opioid crisis, claiming 21 lives a day in Florida.
The Attorney General also revealed some of the emoji codes used by digital dealers to peddle their poison. Pharmacists who have a keen eye on policy, procedure, and patients, the antidote.
My name is Rajdeep Parmar. I'm a pharmacist and pharmacist owner, Melrose Pharmacy.
You're passionate about being a pharmacist. Why?
Pharmacist is itself like the medication, drugs. It's something that like even any advertise something come, I always eager like what is there something new coming in the market. When I reading the news and they say like okay Pfizer is in the phase 3 clinical trial, I'm really excited like what is something coming, you know, like how the medication actually making impact in people's life.
There are so many of those pills and numbers. How do you remember all of it?
That's what everyone say who doesn't know about anything like much about the pharmacy and say like, oh, there are like 1,000 different name of the medication and there are some generic name, there are some brand name, and how do you remember? We learn about the chemical structure, we know about like how the medication works, what are the side effects, and sometimes we connect the name of the medication with those class, with those side effects, and that's how I remember. I'm just giving you one example. You heard the medication name called Lasix. You heard so many times, but you sometimes like how the Lasix, the name came from. Because that medication has a half-life of 6 hours. So that medication only lasts for 6 hours. Last 6 hours. Lasix. And so there are some logic behind some of the name of the medication, and you never forget now, okay, this medication lasts only for 6 hours. So
wow. That's interesting. Explain your number one focus as a pharmacy in the opioid epidemic. We have a huge epidemic with opioids.
So when we heard like opioid epidemic, the small, not story, but like a common like a scenario that I'm gonna tell you first. For example, is a middle-aged woman. She's perfectly healthy. She's living her normal life. She's doing her routine work, routine job, routine household things. One day she was walking on her backyard. She hurt her back. And she is in pain. She started taking the over-the-counter pain medication. She started applying some cream, gel, some patch. Didn't work out. She goes to her primary care doctor. Primary care doctor see her. Primary care doctor prescribing her to do some physical therapy and to control her pain, and because of her bulging disc, she started giving opioids to make her life better. She started taking the medication, and eventually, I'm going a little bit more forward few years, she is now home, she is now disabled, so she is depressed, she cannot work because of her pain, she is in distress. And her pain is still there, and just take care of her like small stuff. She using her opioid medication to just, and now she is addicted. And this is the common situation or the scenario that we heard across the US. If I'm going back to the history, opioid wasn't prescribing before. I'm talking about 1980, before I born. People or the doctor or prescriber now they are not treating pain. The people. They are actually taking under pain medication, so they are suffering, but they are not taking the opioid medication. After 1980, opioid came, and group of the doctor, physician, they don't have much research or not much information, and they started without thinking what are the long-term side effects or what are the things going to come with this opioid. And that's how the people or doctor are prescribing the opioid. Let's do this one. And anything happen pain, let's just treat with the opioid. And what happened with the big organization, for example, Pain Society, Joint Commission, they're also putting now as a pain as one of the fifth vital resource. So anytime you are admitted to the hospital
Right.
or going for something, the fifth question they're going to ask you,
How's your
give me
pain
the,
level?
how much your pain level? Give me the severity from 1 to 10. And they say like, oh, if they have to get better satisfaction rate, the patient's pain level, pain management needs to be addressed. And that's what they're prescribing opioid. When they're discharging from the hospital with a minor surgery, they're dispensing opioid. From last few years, the practice has changed. But before it used to be prescribing like, even if you need 5-day supply, they default by prescribing 30-day supply. 1 month supply. You know, sometimes they go to the primary care doctor. But just think about it when I say like primary care doctor or internal medicine doctor or family medicine. When they go to the doctor, the patient or person is going there to treat their blood pressure, hypertension. They have some other condition. They're going there, and the doctor have like 20 minutes to see that patient. They're treating. Okay, like this patient has this condition, and at the end, patient said, "But I also have chronic pain." So doctor have now, how are you gonna give me more time to spend with time? What exactly has pain? But what happened? Doctor prescribed their diabetic medication, blood pressure medication, and when that comes to the chronic pain, just write it down the prescription. That will take care of their pain. And that's what happened. And this is how the opioid get prescribed more and more. Pharmaceutical company, and they are actually like, you know, they reach out to the pharmacy, doctor, and like all this happening more and more and more. So 1999, that was the first opioid use was increased. In 2010, the second opioid was increased, and that's how the opioid crisis happened. And now, like terms of the pharmacist's responsibility, we always are the gatekeeper, but it's actually, I believe, it's like a responsibility of everyone.
So, how has your job as a pharmacist changed over the years?
So government is really like, they changed the regulation. So instead of prescribing whatever 10 days, 30 days, they're putting the restriction. So they can prescribe only for 3 days for the acute pain. Maximum 7 days if it's exceptional, you know, for them. If the person needs more than that, they go to the pain management doctor or pain management clinic, and they can treat their pain. So in terms of the pharmacy practice also change, because that used to become, so now every prescription when we see, okay, this is for the chronic pain or this is for the acute pain. Okay, this is for acute pain, why the patient is getting pain medication. Or if it's a chronic pain, what is the reason? He has a oncology like the cancer patient, or he has something else, or what other things going on in his life. So we ask normal questions like how long you've been taking, we ask them, we screen them, and then if we have questions, we call the doctor, we verify them, we ask them about the diagnosis, we ask them about the tests they have done, and then we do the documentation, and then we feel more comfortable to dispense those medications. And again, I really appreciate the government to come up with a program called E-Force or PDMP that is giving very, very like openness to the prescriber. Now also prescriber has to see or check the E-Force before they even prescribing any kind of medication. So it's actually closing the loop, not just keeping the pharmacy, but now even prescriber is also kind of aware of how many medication he's taking, decide what is prescribing. So,
what are your concerns with the opioid crisis? And we talked a little bit about that in the beginning, because you talked about how the opioid crisis has changed. So do you have anything else to add to that as to what your concerns are?
right. So I know now a lot of society is working on a lot of organization. Even before in even medical school, they don't have much emphasis on like how to manage pain. Now I think they have more kind of, you know, the education. So education is one of the things that I put, education to the medical doctor, education to the pharmacist, education even to the social service, to providing the psychological service, education to the patient. So those kind of actual surveys that make impact.
Jewel Medley is getting part of her education with Dr. Palmer at Meadows Pharmacy.
I'm actually a pharmacy intern right now. I'm in my last year of school, so I'm a P4. I currently attend Palm Beach Atlantic University in West Palm Beach, Florida, and right now I'm doing my clinical rotations here at Meadows Pharmacy.
Why pharmacy?
I just think it's exciting. So I kind of learned about this field a few years ago. I actually originally wanted to be a pediatrician, but I went to a school that was really promoting pharmacy, so I started talking to a lot of the preceptors and some of the pharmacists, and I just really wanted to learn, like, how do the drugs work through the body. And I took a different route than other people. Like, I completed my bachelor's and I completed my master's, but I knew that this was the path that I still wanted to take. So then I just applied to pharmacy school, and here we are now.
You didn't really start out wanting to be a pharmacist. Tell me about that.
Not 100%. So yeah, I wanted to actually be a pediatrician, but at the time I went to an historically black college that was promoting pharmacy. My mom really kind of pushed me to look at this route, so I did. So then I applied to school, I got in. My second year, I really started learning like the clinical aspects. So, you know, when a patient has an actual diagnosis and how to treat them. And I think what I like about that, although the doctors are writing the scripts, we are the ones doing the double checks to make sure that it's patient safety, make sure that it's patient adherence. And although patients are seeing their doctors, they really see their pharmacists more. So I think it's nice that I'm able to get that rapport with that patient. So, you know, we develop that personal relationship with them. So over time, I definitely developed a love for pharmacy. So I can say now, like, this was the route for me.
What do you learn in pharmacy school about opioids and the crisis that we're in?
Yeah, so we learn about the challenges that patients are suffering right now with pain. We also learn, though, the way that they work throughout the body, you know, how you have to kind of limit your supply to a patient. You don't want them to, doing our due diligence is making sure that they're getting their medications, but that they're getting the right medication at the right time when they're supposed to take it. We don't talk so much about the crisis, but we just want to make sure that, you know, if they are taking these medications, that they are going to be safe as they're taking it. We actually use a system called eForce to see how often a patient is getting it in the state of Florida. So if they haven't filled it within 25 to 28 days, then they're able to have it after those 28 days. But we don't talk too much about it too much in school.
This profession is more than pushing pills. There are ethical and moral responsibilities. How do you navigate all of that?
So I think we just kind of have to learn, you know, go by things that we've learned in school. You know, we go by honesty. You know, we want to value our customers and respect them, but at the same time, we want to make sure we do our due diligence to make sure that we're meeting the patient's needs as well. What else do you mean by ethical dilemmas?
Let's say a friend comes here and asks you to fill a prescription. How do you deal with something like that?
So then I would, you know, treat them just like a usual patient. I would get their name, their date of birth. I would verify the prescription, and I would also want to make sure that we are able to fill it. I wouldn't just fill it because I know someone. I do my due diligence as well to make sure it's able to be filled. Because of, you know, the way we learn and the way we're trained, I would never just ever, you know, give someone a medication because they asked for. They still would have to get their medication, or should I say their prescription, from their doctor, so that way we can properly fill it and go to the proper protocol. I would never just hand over medications or anything like that.
Where do you think changes need to be made in order to help with opioid addiction?
I think communication between the pharmacist and the provider. Although they're writing the scripts, you know, we're the ones verifying it. You know, so we do our due diligence to make sure that they're getting the right quantity, the right dose, and right strength. But we also have to see if they have multiple doctors, which has happened before. You know, a patient will come in and have 2 or 3 prescribers, right? So we want to make sure, are these, you know, the right prescribers? Are they actually checking their diagnosis? Are they being treated, you know, with the right regimen? Because if they're not, then that can cause the patient, you know, some undue harm, you know, eventually. So I would say communication, definitely communication, but more specifically with the doctor, because 9 times out of 10 when you call, you are speaking to the nurse, and I understand that they're busy, you know, but at the end of the day, too, you know, it's all about the patient, having patient-centered care.
So you would prefer to speak with the doctors?
Yeah.
For students out there who, maybe high school students who have not yet decided what they want to do, how would you convince them to think about pharmacy?
Honestly, I would say go for it. I would say try to see if you can get a job. Not, it could be a retail pharmacy, it could be independent like Meadows Pharmacy here, or it could be somewhere in hospital. Get around a pharmacist that they can have a mentor that can kind of help guide them through those steps. I would say go for it, don't run from it. It's going to be a challenge, but it's very, very rewarding in the end.
What more needs to be done to help with the opioid crisis?
So many things, a lot of organizations, they are trying one thing, government is also trying, they have some restriction. Now, for example, I'm just giving you one example so that give you more idea about it, like what about using the CBD or medical marijuana use. So marijuana is Schedule 1 drug, under the government, and now certain states have legalization use of CBD and marijuana, and they're helping some patients, but there is not much research behind those things, and there is no funding behind that because those are the Schedule 1 medication, so there is not any funding because they're considered as an illicit drug, so there is no funding available there, and there is not much research, and that medication not going to be using the way it has to be used. Sometimes they are overusing, they are using for the recreation, sometimes they are not using it. So that needs to be like more research has to be done on those kind of other, like a CBD or medical marijuana. Also the insurance company and government, they also covering the prescription drug as their benefit of the insurance or the insurance benefit of their insurance, but they should also cover the non-pharmacological aspect, like physical therapy. It's covered, but there are some other things like acupuncture, there are some like radiation, there are some new therapies, so that has to also covered by the insurance, so people can go to those kind of side of their treatment and not going toward the opioid use.
Places like New York and Nashville has these centers that people who are addicted can go in and wean themselves, if you will, off of the opioids in a safe environment. Do you think that's the way to go?
I think it's definitely the way to go because the problem is we don't have an authority regulating these products that are coming into our country, and no one's able to look at it and see, if it's laced with fentanyl, is the fentanyl amounts too much. So I think we definitely need an authority figure to be able to help combat the number of deaths and overdose-related deaths in the country. Provide treatment facilities where people can go into these facilities without being judged and get free access to the medication that they need to help go on with their lives. And this will be regulated because they can trust it because they know that when they get their high, they're not going to possibly die or overdose. And I think that this will be a more attractive option, especially if it is free to the public, for sure.
What do you say to people who would say, well, we're promoting drug use?
At this point, you're not really, drug use is still going to happen. You can have these treatment facilities and people might say that, but at the end of the day, we have a bigger problem, and the problem is these overdose-related deaths is happening, and they're happening very rampant, and it's killing a lot of people in this country. And that is the bigger problem, and we need to find a way to resolve that problem. And this will be the best way, where people can go to these facilities and get these medications, because we also have to remember, if they stop it completely, withdrawal could also kill them too. So they need to take a medication to be able to help them keep going with their lives and help with their quality of life. And so these facilities can be a gateway to actually help them change that path in their lives while they can receive the medication that they need in a safe manner.
A study showed that only about 10% of people with opioid use disorder receive treatment for it. Do you see telehealth as a possible solution to improve access to care?
So I think honestly one of the biggest barriers to access is probably financial reasons. People who probably do battle with it are probably scared of how much it will cost them to go see a doctor about it, or how much the meds will cost. And so I think that's definitely one of the biggest barriers. Second of all, I think telehealth could help. especially because, sometimes we have patients where transportation is an issue for them. They don't know how they're going to get around or see a doctor. So I think definitely that would help some patients who are struggling with that. Definitely telehealth, I think, could potentially help. I don't see anything wrong with it for sure. The only thing is there's only so much you can get from a patient, virtually. And sometimes it's more meaningful when the conversation is in person.
Do you think if we had access to real-time opioid data instead of data that's published months or years later, would that help with combating the opioid crisis? If so, why?
I think it's always nice to have accurate data of what's actually going on. I mean, real-time data would be amazing, but it's not realistic. It would be great, and I think it could help us to know where we are coming from and where we're at now and what needs to be done. And the things that we have done, are they even working? And what do we need to improve it?
A recent study showed that there were disparities in treatment for people who went to the emergency room for an opioid addiction. Or between 2016 and 2020, blacks and Hispanics were given, am I pronouncing that right, buprenorphine?
Buprenorphine, yeah.
Buprenorphine in the emergency department at lower rates than non-Hispanic whites. Do you have any idea as to why this was the case?
So that is an interesting finding. Generally, we don't tend to see providers prescribe buprenorphine in the emergency department, mainly because not all prescribers can prescribe it. Usually prescribers have to undergo training and get a waiver, a DEA waiver on their license to be able to prescribe buprenorphine. So you won't find a lot of emergency department physicians that do have that license or that waiver. So we won't usually see it in that setting, but you will see it in a lot of primary care settings or office clinic settings, outpatient. So the disparity, I would like to say, is probably due to financial reasons. Generally, when you're going to see a primary care physician, they're looking to see if you have insurance or are you able to pay out of pocket. And even if you do have insurance, can you pay that copay? The copay might be very high for some people. So again, this might be one of the reasons for the disparities. Low-income families may not be able to get treatment for opioid use disorder. And so those who are financially steady, this is not a problem for them because buprenorphine is actually a very expensive medication. So unlike methadone, that's usually provided in federally insured clinics, where it's guaranteed that the government will cover it, buprenorphine, that's not the case. And so it is expensive, and generally you will need insurance to be able to cover it, especially if you're getting it from a pharmacy or from a provider in office, or if you don't have insurance, the ability to pay out of pocket. And so this is why there is a big disparity.
Can you tell us about the drug buprenorphine and how it helps to combat opioid addiction?
Great question. So buprenorphine is, a way it works, it's still an opioid, but we like to call it a partial opioid. So it does work on certain receptors in your brain, but it works on the receptors that don't cause that high or don't cause that dependence or abuse. So it still will help with the pain, and they love to use this drug, especially for patients who are going through withdrawal, because you never want to completely immediately stop opioids in a patient who's been taking it chronically. You want to be able to taper them down. You never want to stop it immediately. So buprenorphine is great to just target the opioid receptors, help with pain, while at the same time not causing that high that people get that causes them to abuse opioids. And it's crazy because this concept also applies to antidepressants too. So antidepressants, similar like to opioids, you can't just stop them automatically. If you start taking them, you can't just say, hey, I don't want to take this anymore, because then some side effects will occur because your body's been so sensitive to it.
What's the difference between buprenorphine and methadone?
So the mechanism of action is a bit different for both. Buprenorphine is a lot newer, so generally newer medications tend to be more expensive, especially because the companies have a patent on it, and if they don't have any generics for it, they are going to be quite pricey. Methadone's been around for ages, and so that's why the government's willing to support it and fund it.
It all comes down, it seems, to money.
Yes. And so those who are financially steady, this is not a problem for them because buprenorphine is actually a very expensive medication. So unlike methadone, that's usually provided in federally insured clinics where it's guaranteed that the government will cover it, buprenorphine, that's not the case. And so it is expensive, and generally you will need insurance to be able to cover it, especially if you're getting it from a pharmacy or from a provider in office.
I don't think the answer is to build more rehabs necessarily. There's a certain level of accountability that has to happen, and it's difficult. So we have rehabs, people come in and out. I don't know that building more is really the key, but I do think that research to change and coming up with new and innovative ways to treat addiction probably is more on par. Another thing is that I think that when you look at the whole problem, the addict isn't the only person that's affected, right? So I don't think the money goes only to the person who has developed the addiction, but really to the whole community to prevent new addictions, to prevent new problems. And because we know that addiction is a multifaceted problem, and it's a long-term problem, almost like obesity, it needs a multidisciplined approach as well as a long-term solution. So some of those things maybe are, dialing into people's pain scales and, giving them some level of control over pain management that doesn't necessarily involve just medication. So using, trying to find new tools like more mental health treatment. There are some, radio frequency to alleviate pain, hyperbarics for, or cognitive therapy for just resetting the brain. So those are the ways that I would say to push some of that, something different and more innovative than what we've been doing thus far.
Well, I would say thank you guys so much for joining us this evening. It is such a pleasure to have all of you here with us. Dr. Shakoya and Dr. Parma, thank you so much for sitting down with me, allowing us to come into your space and just to have such a pleasant conversation. We have lots of questions, so we're going to jump right into it, and we'll start with you, Dr. Shakoya. What are some of the fears that patients might have when taking opioids for pain?
Hello. Hi,
Hi.
everyone. So some of the fears that patients might have taking opioids is a common fear that they have is possibly being addicted to them, and also the stigma, that comes from addiction that we see in the media. So most patients are usually aware of the most common side effects of euphoria from opioids, but they're not always aware of other serious side effects that are associated with opioids, such as constipation, which can actually get quite severe. Nausea and vomiting, dizziness, drowsiness, slowed breathing, especially if you're taking concurrent medications that can also slow your breathing down. So there's definitely many other side effects that that many patients are not aware of. And I definitely think the most common fear that patients have is being addicted possibly to opioids.
How do you, for a patient that really needs to take an opioid, how do you talk to them about their fears? How do you deal with that? What do you say to them?
Well, how I would approach it would be, a benefit versus risk in their situation. So if they've exhausted all other means of non-opioid medications and their pain's still uncontrolled, I would bring it up to them that, hey, this can really help improve your quality of life. This can help control your pain. There are some side effects, but because you really need this for your pain, most likely you're not going to become addicted. Because what we tend to find is that most people who do end up becoming addicted to opioids, they actually never really needed it in the first place. So those who do need it don't tend to become addicted to it.
Okay. Dr. Palmer, what do you do if you believe a patient was incorrectly prescribed opioids? Is this a situation that happen often? Dr.
Yes.
Palmer?
So yes. So can you hear me, right?
Yes, sir.
Okay. No, definitely. So what happens sometimes that you believe is the prescription is inappropriately prescribed. So you not just clinically decide, you also decide as a professionally. You can call doctor, not just the staff of the doctor office. You speak with the doctor itself. You talk to the patient, and still you have to maintain those the patient relationship with the doctor, and the where doctor is. So basically, you have to judge with the clinically and professionally, and then you decide whether it's meeting with the guideline, it is meeting with the state and the federal law. You document, and then you are comfortable, then you prescribe, because there's a lot of time it happens when you see this prescription is not appropriate, but these are the way you can actually try to avoid.
Dr. Shakoya, if the guidelines are changed and the rules are more lenient, do you foresee the opioid crisis worsening? And let's talk about that a little bit. What's your thought?
Like I said before, I feel like the guidelines are fair. And I definitely feel like if they change it to make it more lenient, many individuals who may not require opioids will receive them. And that is usually the population who tends to abuse opioids and hence become addicted. So those who require opioids are not known to often become addicted as those who did not require them in the first place. So definitely I can see it possibly not improving an opioid crisis that we're still struggling to handle.
Dr. Palmer, what are some other prescription drugs that can be used, or that can also be abused when you prescribe them?
So recently, the prescription medication gabapentin, that has been scrutinized for the potential like a misuse, and now even we are speculating that that's maybe the potential the drug epidemic. A lot of people, a lot of doctor and the patient, they're using the gabapentin, and some of the state even considering to put gabapentin into as a class of control medications because of the happening with a lot of misuse. So that's one of the medication. Yeah.
Are there any more drugs that are on that list, or any more drugs that you think should be on that list that are being misused or has the potential to be abused?
The one I see is the gabapentin is the main one right now. Yeah.
Okay.
Yeah.
Dr. Shakoya, since money is a determining factor to access drugs such as, and please help me with this, you and I talked about this word, buprenorphine. What are some ways in which low-income patients can receive the same level of care?
So that is a great question. And there are actually a couple options for low-income patients to receive treatment for opioid addiction. One way is actually obtaining coverage through Medicaid, especially if they qualify from a financial aspect, or they can actually contact the Substance Abuse Mental Health Services Administration 24/7 hotline, also known as SAMHSA. WOM can actually advise on local state programs that can provide public assistance to low-income families.
So we have a question here, and I'm very interested in this question as well. If someone is prescribed opioid medications, are there specific foods or medications that they should avoid whilst taking an opioid?
Not necessarily foods as much, but you do have to worry about possibly other medications that can have similar side effects as opioids.
And what are some of those medications?
So examples of those would be benzodiazepines. So benzodiazepines are a class of drugs that are commonly used for anxiety. And Unfortunately, they do have a side effect of causing respiratory depression. And so hence we have to be careful of patients who are taking both medications.
Okay. Dr. Palmer, do you think insurance companies should reimburse patients for non-pharmaceutical pain management strategies such as yoga and acupuncture? You and I started having a conversation about that. It was very interesting.
Definitely, the idea of using the non-pharmaceutical intervention should be in the medication therapy. And there are established evidence-based now practice like, music, work with the dementia studies. So, and we all should recommend lifestyle modification. We always recommend those lifestyle modification in a lot of disease, but that should be our like a first preference on the lifestyle modification. And insurance companies should think about to include acupuncture, yoga, and reimburse for those patients. So they're not thinking toward the first option as a pain medication, but try all these things and then doesn't work and keep opioid as a last resource.
Why would, when you're doing yoga and acupuncture, how does that help? For somebody who probably has never done it or say, well, that's not going to work. Why would a doctor recommend that? Can you talk a little bit more about that?
So it's all about mental, so first it's all about mental. So if you have the mental peace, so it's like a yoga and acupuncture, it's just giving you the relaxation or sometimes it's the radiation and some of the music therapy. So those can actually make it work better with some medications, and that maybe impact not just thinking about to start medication. So the thing is the way we are living in the country, first option it comes like, okay, I'm gonna take this pill and I'm gonna be back to normal next day, so but if they think in the long run this therapy works.
And Dr. Shakoya, what do you think in terms of, do you ever have a situation where you can talk to a patient, maybe suggest to them, like Dr. Palmer is saying about yoga and different kind of therapies like acupuncture?
Yes, definitely. It's always good that you complement opioid therapy with non-pharmacologic means, and so that could be through either going to physical therapy, acupuncture if it helps in their situation, and also even just using some over-the-counter pain medication too. Sometimes we forget we have access to that, actually easier access to that than opioids, for instance. So just even utilizing over-the-counter medications as well can help.
Okay. I think I have another question coming here. What kind of food can help reduce the cravings for opioids? And any one of you can answer that question. Dr. Palmer? Dr. Shakoya, are you there?
Sorry, I just want to make sure I'm understanding your question. Yeah. So you're asking,
is there any type of food that people can eat that would reduce opioid cravings?
For someone that's battling with opioid abuse disorder?
Yes.
Not that I personally know of. Usually our go-to is more so the pharmacological aspect with opioids like buprenorphine or methadone if indicated. But perhaps someone else can provide some insight into that.
Can anybody provide some insight into that? That's the question that we had here. If anybody's on that can provide some insight into that. If not, we'll get the answer for you a little bit later. The person that asked that question will get an answer for you on that a little bit later. So we've got a few more minutes left. And before we leave, I'll let both of the doctors here give us their final opinion as a pharmacist about opioids. And Dr. Shakoya, I'll start with you. Let's give us your final opinion as a pharmacist about opioids.
We do have to remember that opioids are beneficial in certain populations. For instance, I work majorly with cancer patients, and opioids are a hallmark of therapy to help control their pain. We do have to recognize that there's populations who can really benefit from it, and there's populations who don't really need to go to it as a first line and more preferred as a last line. So I think if we, as providers, we're just ensuring that we're balancing benefit versus risk for patients and just really looking at the individual patient, considering their background. Do they have the potential for abuse? Do we really want to go down the path of opioids for this specific patient? But overall, there is a big benefit to them, even though there's so much stigma, negative stigma to them in the media. But I think the big thing is just being responsible. And I think because we were as responsible in the past is why we have this problem. So now we just have to remember that there's patients who need it, but at the same time, we do have a crisis that we have to solve and resolve with time. And so with that comes, possibly needing more research, as was mentioned earlier, and just providing easier access and more education to opioid treatment programs, so people can help get over their addiction in a safe manner and effective manner as well.
And Dr. Farmer, before we get to your opinion, your final opinion as a pharmacist, I've got one more question I got to get in here. What is the limit of how many pain medications one can take for pain? For example, there is a limit to how many Tylenol one can take in 24 hours. So what's the limit of how many pain medications they can take for pain? Can any one of you guys can jump in and answer that?
So there actually isn't, surprisingly, there actually really isn't a limit for opioids because it's dependent on the individual. But if they are taking it in combination with acetaminophen, or some may know as Tylenol, we do have to keep that in mind, as there is a restriction with the maximum amount of Tylenol you can take in a day. Ideally, they say no more than 4 grams max in a whole day. So that can obviously change, how much a patient could take if they are taking an opioid that's in combination with acetaminophen. But ideally, opioids, there is no max. We just titrate, according to their pain and what they can tolerate. Now, there might be a max if it does cause respiratory depression at a certain dose. So it would be more of a clinical max, and it's dependent per the patient.
Okay, Dr. Shakoya, thank you so much. I really appreciate everything. We've learned a lot here from you and all of our guests tonight. Thank you guys. Thanks everyone for joining us today. Please wait until the end of the webinar to scan the QR code to obtain your free 1 credit of CME CEU for today. For this series, we will have one last episode next month. And to learn more about opioids, please visit www.T.Leroy.JeffersonMedicalSociety.org/opioids. So there's a lot more information on there. And you can also log on to our website to see all of our series. If you've missed anything, you can go back and watch these episodes again. We want to say thank you again to everybody who will participate, and we'll see everybody again next time. I'm Sandy Collier. Have a great evening.
On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We also would like to thank our team and panelists for helping us make this project possible. If you would like more information on T. Leroy Jefferson Medical Society, please visit our website at tljmedicalsociety.org.